Yeah, welcome to Decoding CTO, case 38. I'm Dr. Sharath Reddy, interventional cardiologist, Medicover Hospitals, Hyderabad. Today I'm bringing up a case of IVUS guided retrograde proximal cap puncture. To come to the case, my patient is a 47-year-old male presented with non-ST elevation MI with high troponin values, with good LV function and normal sinus rhythm. CAG done revealed triple vessel disease. In fact, high syntax score with comorbidities like diabetes and hypertension. Patient was not willing for surgery, and we considered multivessel PCI for him. This was the angiogram. You can see RCA, mid RCA is total occlusion, and there is a lesion before the total occlusion, significant lesion, and also there is a big side branch, that is RV branch, coming just before the total occlusion. And you can see in left short, so the RCA is filling retrogradely, and we can see it's a short CTO only. It's not looking like long CTO. So this is the left system, and there is a significant lesion in LAD, and I think this was the culprit lesion for his non-ST elevation MI. And another problem was his septal, which is giving a good connection to right coronary arteries, originating at the site of lesions. So if at all I had to use retrograde, so that retrograde will be through the stent struts. So that's something which we should be mindful of while doing LAD intervention, not to occlude the donor septal collateral. So this was the anatomicogram. You can see here, this is the total occlusion. You can see there is a small stump. You will observe only when you see it very carefully. This was a small stump, and which can be used for antegrade wiring. And otherwise, it's a short CTO, much of angulation, no calcium, nothing. The only problem was angle of attack when compared to when your wire is in RV branch is almost more than 90 degrees. That was the only problem for antegrade cap puncture. So it's a high angle of attack. So yeah, the wiring strategy must be like this. Before you start wiring, first always treat inflow lesions. So you have to thoroughly treat these lesions so that you can send all the gear down, and then start wiring this proximal cap. So probably filter XTR followed by escalation to Gaia 2 if required. And yes, angle of attack can create a problem. Yeah, this is how you have to wire this. And if that doesn't work, you can go retrograde and puncture this proximal cap by keeping IVUS in RV branch. So that was a plan of wiring for the CTO. So these were the challenges. High angle of attack, which I told you already. Probably WMN would mitigate pushability of the wire a little bit, but sometimes it may not work as well. And the proximal lesion, yes, always predilate inflow lesions into CTO first before going for further wiring of CTO to get an unhindered access to CTO. And donor vessel disease, in this case, yeah, if we are going retrograde, so it makes sense treat donor vessel before going retrograde, and be mindful of septal jailing, because that was the only retrograde collateral which was available in this case for retrograde wiring. So we went ahead and did LED because that was a culprit vessel. But so what we made sure is we dilated septal before stunting LED to keep it patent, and even stunt is kept across LED donor vessel by keeping a safety wire or access wire into the septal. That is very important. So keep an access wire into septal. So we jailed a wire into septal through the stunt to have continuous access. And then we started right coronary artery. So we treated inflow lesion first with a 2.5 balloon, and then started wiring proximal cap using first using fine cross, then using double lumen catheter. But we can see the angle of attack was quite bad, and despite repeated attempts, wire couldn't negotiate into the proximal cap, so it was just buckling and going down. And here escalating to Conquest or Harnett wires was another possibility. Usually I use Harnett 10 or 14. Since angle of attack was too bad, so I stopped short of escalation and moved to retrograde due to safety perspective. So when retrograde, so wired is septal, keeping the jailed wire intact, and once wiring is done, we pre-dilated septal artery to move the struts away from ostium, and then took a caravel. So this is my preferred catheter when I have to go through the stunt struts. Caravel goes nicely through the stunt struts into the septal, so you can see how nicely it is going after pre-dilatation. So, and we checked for collateral anatomy. This was a good septal collateral, and then we used CO03 and crossed septal. You can see we crossed septal and then reached the distal cap. In fact, the CTO was quite short. So then we brought a IVUS catheter into RV branch, and then we are checking for the proximal cap. You can see this is where the media is disappearing, and that is where you can see here this is the proximal cap. So yeah, so we can identify proximal cap here. So you can see where the media is disappearing. This is where the media is completely disappearing. Rest of the place media is visible. So this is where your main vessel is joining, and you can see this is the proximal cap. You can see this is the nipple which is visible in angiography, and where we try to enter with Gaia 2. And honestly, there was no calcium here, but mainly because of angle of attack, wire couldn't perforate this proximal cap. And now we escalated retrograde wire to Gaia 2. So this is Gaia 2 wire, and we kept IVUS in RV branch to see the tip of the Gaia 2. So this is the tip of the Gaia 2, this is the tip of the Gaia 2, which is almost close to the proximal cap. So close to the proximal cap. So the tip here is basically you have to take wire as close as possible to the IVUS catheter in both looking in IVUS as well as in fluoro, and then enter into the main vessel. So if you're not sure about the wire location, so that is a better strategy. So if your wire goes close to the carina, chances of occlusion of side branch is very less. And how to identify tip is by forward and backward movement of IVUS catheter, we can identify the tip and tip direction, and then we can navigate tip into the proximal cap. So we can see here, so we navigated tip into proximal. This is close to the proximal cap. This is the proximal cap, and then we pushed it across proximal cap. You can see now the tip is into the lumen visible. It is across the proximal cap, and yeah, now you can see the wire is into the main vessel. So we navigated under IVUS into the main vessel, and now we have to confirm, retrograde wire entry to the proximal cap. So you can see here, this is nothing is visible here, and then you can see this is a white tip which is visible, and now you can see this is a proximal cap, and your wire is coming into the proximal cap, and then it is within the proximal cap. That is a nipple which is visible in IVUS, as well as what was visible in angiogram, and then it entered into the main vessel. So this course was perfect, and we won't end up in losing this side branch. So we pre-dilated with a 2 mm balloon. We can always recheck IVUS from the main vessel after pre-dilatation. This is also one important step to confirm your side branch entry. So what you have to see here is, so when so just let me stop, and yeah, so when you are, so yeah, okay, so when you're coming from distal vessel, so when you're coming from the distal vessel, so the side branch wire, we can see the side branch wire here at 3 o'clock, and this is the side branch entry. We shouldn't see any flap in front of side branch entry. So that is the key. So there shouldn't be any flap here. So now we can see while playing, so there is no flap in front of side branch entry. So that indicates your entry was perfect. So if you see any flap, we have to change strategy. Probably we have to use a cutting balloon to break the flap, and so that after stunting you don't lose your side branch. So post that we stunted the RCA, and you can see this is the final result of right coronary artery. Yeah, so to conclude, IVUS guided retrograde proximal cap puncture is feasible in suitable cases where you can send IVUS into the proximal side branch, and principles of tip detection would help in steering retrograde wire through the proximal cap. Confirm wire entry before pre-dilatation by doing IVUS from side branch. After pre-dilatation, do an IVUS to reconfirm absence of flap over side branch entry, so that you won't lose side branch. Thank you. Subscribe this channel, Interventional Strategies, to see more and more such learning case videos.